Okay, awesome. I guess we can get started now then. Hello, everyone, and welcome to Breaking Barriers, Empowering Black Women and Girls in Health and Wellness. This session is brought to you by the Empower Project, a partnership between Howard University and Health HIV, sponsored by the PACE Gilead Grant. We are so glad to have you join us for this important virtual town hall. Today, we will be delving into critical health issues that impact Black women and girls, issues that often go unspoken, yet deeply affect our communities. Our conversation will focus on breaking the stigma surrounding topics like mental health, reproductive health, sexual health, and access to equitable healthcare services. We are making an intentional effort to continue to uplift Black women and girls, not only with this session today, but other initiatives as part of our Empower Project, such as our Girlfriends podcast and our Wellness Chronicles. The podcast is dedicated to addressing the unshakable strength shown in the unique challenges faced by Black women and girls, particularly in the context of sexual health, mental well being, and access to healthcare. The Wellness Chronicles are a 1 minute video series that deliver quick, impactful health facts. We have a link to our program webpage in the chat for you to check out both of these resources. But on another note, our session today is about fostering a supportive and stigma-free environment where we can ask questions, learn, and take actionable steps to improve health outcomes for Black women and girls. By the end of today's session, we hope you'll be able to walk away with a deeper understanding of how stigma shapes healthcare experiences, strategies to address and overcome stigma in healthcare settings, knowledge of 3 critical health issues that disproportionately affect Black women and girls, and solutions to address them, communication tools to better advocate for health, and lastly, well being for yourself, your loved ones, and your community. We have brought today together a dynamic panel of experts who will share their insights, strategies, and expertise. Our first keynote speaker is Stacey Ann Dice, Acting Deputy Chief of Behavioral Health Integration at the Center for HIV STI Integration and Capacity at the Maryland Department of Health, also known as MDH. Next, we have Dr. Owinga, Board Certified Family Medicine Program and Medical Director of Title X at CCI Greenway. And lastly, but certainly not least, we have Tito Phillip, who is a junior biology major, health education minor with a concentration, y'all, in maternal health, at the illustrious Howard University, my alma mater. And I am your host, Taylor Owens. I'm the capacity building coordinator at Health HIV. And before we jump start our questions, the time is now 4:06. I want to ask our panelists, is there anything you'd like to say before we get started?
Let's do this.
I'm excited to be here.
Awesome. Okay, so our first question is going to be, and I'm gonna start it off easy, okay, because I did mix them up a little bit, but they flow. It's okay. Our first question is going to be, how does stigma manifest in the healthcare experiences of Black women and girls, and what are some real-world examples of its impact on health outcomes?
Okay.
You want to
forgot
take?
who was supposed to answer first.
Everybody, whoever wants to go first is more than welcome to go first.
Go ahead, Stacey. You got this.
So what we know number-wise, what we see number-wise, are child maternal health rates, morbidity and mortality rates. We see rates of diabetes, high rates of diabetes amongst African American women, heart disease. Let's see. There are many other Dr. O.
We have with
Tito.
our adolescents, we have teenage pregnancies. We have increased risk of STIs. We know that our numbers are high with our 13 to 64, 13, sorry, to 24 age group with acquiring STIs and HIV. So there are a lot of things that our African American females of color that are experiencing that their white counterparts do not experience. Also, maybe due to lack of resources on the family's part, lack of education, decrease access to resources, leading to a lot of these issues.
Not to forget higher rates of HIV amongst African American women when compared to women of other races as well.
To
You know,
add
the stick.
on, oh, I'm sorry.
All right, no, go ahead, go
I was
ahead.
going to say, to add on, I think one other thing too is a lot of the times, like one thing that's very common is they always assume that like, oh, like Black women have a higher pain tolerance, stuff like that. And so that always ends up leading to other issues as well, like just assuming that like, oh, they can take on more than like a white woman may possibly be able to.
Yeah. And just as a provider, just that the options that are offered are different at times. With to the population, and it's just culturally that the stigmas that come, the biggest stigmas that come with just expecting that our young girls are having multiple partners. That's just assumed. They're assumed, they are coming from single parent households and not dual parent households. I personally, this is not a clinical question, but I remember in undergrad, when I said I wanted to be a physician, I was told that I should try to strive for more achievable goals. And that, medical assistant or, there are other programs that would probably be, fitting. So I wouldn't line myself up for disappointment. I should try to go for achievable goals. I remember that Dr. Churchill telling me that. And despite getting higher grades than a white counterpart who, well, maybe you need to put more time into some of your studies and we can help you find some resources. I was just told to get more achievable, to reach for achievable goals.
We're so glad you didn't listen.
Thank you.
We're so glad you didn't listen.
Little did he know that was the fire I needed to kick things into gear.
Yeah.
Thank you. Does anyone else want to comment before I add my little 2 cents and then jump to the next question?
Go ahead.
No? Okay. I was gonna say that I think that stigma shows up in healthcare experiences for Black women. Honestly and really and truly, just from my personal experience, is when we are dismissed, ignored, or we're judged instead of being heard. I think that when we remove the stigma, that's when the healing can begin because that's when we can normalize the conversations, right? Even when you don't have the knowledge or you don't understand or you can't repeat what your doctor just said, if you hear us when we're talking, then stigma won't manifest because it'll be an open space for us to communicate from the patient provider perspective and setting that we are in conjunction with healthcare. So moving into our next question, what are some effective approaches to improving access to equitable healthcare services for Black women and girls, particularly in undeserved areas? And I'm going to throw that question at Stacy and Tito, but Dr. Owinga, you can definitely jump in.
Okay.
Okay, so we have, so Taylor, just to tack on to what you stated, and you're absolutely right. But also internalized stigma. Like I can't tell you how much it grinds my gears when I hear someone talk about those fast tail girls, right? And if we're talking about girls, how fast could they really be? Right? And if that is the case, then what are we doing to educate them on what they need to know to keep themselves safe? Right? So just to put that in there, there's some internalized stigma that we have, especially in the Black and Brown communities, that we also need to be aware of and challenge. As far as approaches, Dr. Winga and I actually spoke a little bit about this, continuing the conversation, like who's talking to who, and we should be talking to one another, right? It shouldn't be. No longer are we in the era of shh, we can't talk about that, we can't talk about that, right? The 50s are gone, y'all. The 60s are gone, the 70s are gone, the 80s are gone. And we have so much access to information, but also we're not talking about it. So we have this culture that likes to use sex to sell hamburgers and cars, but yet we can't talk about it in a manner that is mature, in a manner that is healthy, in a manner that is sex positive. Because let's face it, we don't not have we have sex for a reason, right? So not for nothing, having the conversations. And I shared, and I will share And I had the honor of one of well, a few of our programs here in the state of Maryland are trying to outreach to Black and Brown women more. One of the tools we are inviting them to use is Sister to Sister. And our Health HIV family has been pivotal in its relaunch. I remember the first iteration not too long ago, because I'm not going to age myself, that I was trained in the first time around. And it has been revised and updated. I'm going to say bravo, Health HIV, because I was at the training not too long ago, and it was wonderful. But it is a conversation method, right? It is scripted, but it's also a way for folks to have conversations. And in these conversations, in Sister to Sister especially, and there are several other brief interventions, because this one is you're meeting a patient, patient, client, constituent, whatever you call folks coming into your offices. You're meeting them there, and you're meeting with someone who has been trained in Sister to Sister, and you're having this type of conversation that pretty much gives you the message that you're worth testing. You are worth knowing your status. You are worth knowing how to use condoms. You are worth knowing how to negotiate condom usage. You're worth it, right? Which I think is a message that some folks have not, too many of us, and too many times Black and Brown women are missed in that type of messaging, and especially in the realm of public health and health, right? We've been totally dismissed in many ways. So being able to have these type of conversations gives us a chance to allow folks to see themselves being worthy, being healthy. I can do this, self efficacy, knowledge, whatever folks are needing. So I think a huge part of it is us just not having those conversations, just not employing those tools of how we talk to one another, is a big one for me. So we are helping a few of our vendors include Sister to Sister in their range of practice in their clinics, federally qualified health centers. Also, a few other interventions. I don't know how many folks remember the days of Ebbies and Devies. We are actually employing some of those in the state of Maryland. But the real overarching theme of that is engaging folks in conversation, actively listening to them, and asking your open-ended questions so folks can get the right information.
Just to briefly add on to that, I do think that it is important to have these conversations. I feel like a lot of times too, it is really hard to go to healthcare providers and explain what like the issue may be. You know, it's hard to kind of just open up to somebody you may not be comfortable with or know, and like be like, you know, like I think this is wrong. You know, like what can you do to help? And so I think also like having more education and stuff on like what the issue may be as well. Like being able to have these conversations are important. And then also like doing your own research and like stuff like that is also very important because it'll make it easier for you when you do go in and you do go into a healthcare center and you're like, oh, you know, I need help. It'll be more comfortable. It'll be easier to do so.
Yeah, for me as a provider, I'll just give my 2 cents. It's very important to be able to have these conversations, like Stacey said, that no one wants to talk about sex, but everyone's having it. You know, we're just now getting to the age where they're playing that commercial with the, you know, deodorant, you know, that, you know, can everywhere that you put all over your body. And it's, you know, women were not supposed to talk about the certain things. You know, we grew up in an era where they tell boys to use condoms and tell girls not to have sex. So like, who are these boys having sex with? You know, so now coming from a place of sex empowerment and safe sex and harm reduction. So I tell my teens, I don't care, you know what? I want you to not have sex and wait, but if you're not and you're going to have sex, let me tell you how to have the safest sex that you can. And this is what you're going to do. And a lot of them are surprised. What? There's something to prevent HIV? There's something. I'm like, yes, there is something for everything. You just need to know, you just need to use it. So it's not only important for us to prioritize the conversations. We have to normalize them. It needs to be part of the routine visit. Oh, so what do you take for, same way, what do you take for your headaches? Ibuprofen. What do you take for PrEP? Oh, I'm on the shot. Oh, I do this. It needs to be okay. But there is a stigma that comes with it when a woman, and that I've been hearing, and I've been asking my patients, that if they do tell someone that they're on PrEP, that the notion is that they're sleeping around. And we need to work on figuring out how to help our everybody, all of us, get over that. It just means I want to protect myself. You don't wait till you're pregnant to get on birth control. So why should I wait to, I can't get on PrEP if I have HIV. I've missed a shot. So making that make sense to people.
And one common thread that I have caught from each of your answers was just making sure that we are putting the effective approaches where it's needed the most. So like in the mobile clinics, in the telehealth options, in the funding opportunities in community centers that are run by people who look like us. And if not, if they don't look like us, at least who have taken the time to get to know who we are, culturally speaking. And then making sure obviously that it's culturally competent care that respects, Black women's health and Black women, to even like be able to close that gap, because I don't think that people understand that access is about more than just proximity, because I can live right next door to the clinic or right across from the clinic, but if there's no trust, I'm not coming if I don't need you, right? And that's the mentality that we have. So that was just my little 2 cents that I got from Alvi, because that was a learning experience. And with that, Dr. O, I have a question for you, and
Okay.
everyone else can
Okay.
find it as well. But Dr. O, because of the comments that you made,
Okay.
I want to know, what key communication skills should a person develop to even effectively have or advocate for health and well-being for Black women and girls in various healthcare settings?
Clear communication and a clear knowledge of what you don't know. I love when someone says, I go into the room assuming, I don't care if you say, yeah, I'm a doctor. I don't care. I'm going to speak to you as if you don't know anything. And I will, curtail the conversation and how I speak based off of, how I'm picking up the cues. Like, you understand what I'm saying? It, like you said, you can be in a doctor's office. If I say, are you sexually active? And you say no, but because you don't understand what that means, I'm not doing my job. So I may not ask, are you sexually active? Because then someone says no. When they say no, I assume everyone's having sex. So when you say no, I look at you like you're crazy. I'm like, okay, like, you're not having sex, like no one's sticking this inside of you. You're not. And they're like, oh yeah, I do that. I'm like, that's sex. I'm like, oh, when you said active, I meant right now. I'm like, no, right now we in the office. So I didn't mean right now. We couldn't have been meaning right now. But, and sometimes it's different for everybody. Are you sexually active? Oh, I haven't had sex in a while. How long? Last Tuesday? Today is Friday. So you had, and there, for them, that's not sexually active. Like, that's a drought. And someone else might have a drought where, they're like, I haven't had sex in 35 years. I'm like, yeah, that's a drought. Um, but it looks different for everyone. So just taking the words that they're saying isn't enough. I dive in and I tell them, listen, I'm nosy. So take it how you want. In order for me to take care of you, I need to be as nosy as possible. I want to know everything, and I tell a lot of my young girls, you haven't even had an orgasm yet, and you control this. So we have to empower them, because what I've noticed with our counterparts is that they empower those young ladies. The mother's bringing her, you're going to get on your birth control and you're going to do this and you're going to do that. But in our culture, our parents, they don't want to speak about it. They don't want to talk about it. And if you're doing this, you're going to get in trouble. It's punitive. We have to start to just change the culture and understand that this is part of harm reduction.
Stacy or Tito, would you like to comment?
I am a huge advocate, and Leo knows this, of motivational interviewing. It is a style of conversation in which we are allowing folks to tell us who they are, right? So we are asking those open-ended questions, those who, what, when, wheres, Not exactly why, because sometimes why is judgy, but we are asking those questions that are allowing folks to tell us about them, right? So as Dr. O said, we're asking the questions, what kind of sex you having, right? What is going where? How often is that happening? What does that look like? Right. So we're allowing folks to expound so that we can get the better picture, so we can be our response, our offerings can be what they need, because it could be a little bit of knowledge. Well, boo, you might need a smaller condom, or you might need a larger condom. We have some here. Have you thought about the internal or external condom? Let me show you what the internal condom can do, right? And how we can make it better. So those conversations, how we have conversations, we have to pivot from asking those closed-ended questions, right? Because once we get a yes or a no, that's it. That's the end of the conversation. But if we start expounding with open-ended questions, who, what, when, where, whys, then we start to get to the meat of things, and we're able to actually communicate, right? We're actually, you're giving me something, I'm giving you something, we working together on this thing, because the fact of the matter is, that's what it's about, right? Listening and sharing and learning from one another to get the better result, so to speak.
And the last also, like, even though like my heart is with my adolescents, because I feel like that's where we need to, to get, we need to reach out to. But also I have a lot of patients and people now like in their 40s that are like adolescents, because they're getting out of these marriages that they were in since like that my high school boyfriend, and they're out there, and sex is, it's still always, it's a man's world still. Like, I have people telling me they go to sex parties, and the sex parties, it's women are free, all the women can go in as many as they want, but men need to come with a woman. So it's like, so then there's an abundance of women there, and there might be two men. So it's like all the women are there for the men. So the culture is still there. So, it's trying to, empower them. And okay, yes, you're going to these sex parties. Are you protecting yourself? Do you know about Doxy prep? Do you know about, HIV prep? Have as much fun, have as much sex as you want, but make sure it's safe sex. you know People are going there and they're just saying, hey, what's your status? I'm clean, I'm good. That's it. That's not enough. And encouraging them and not shaming. I ask a patient, are you sexually active? I'm married. Okay, how many partners do you have? I said, I'm married. I know what you said, and I asked you, how many partners do you have? And I'm not surprised. I would say maybe 7 out of 10 times I'll hear I have a husband and I have a boyfriend. But the fact that I let them know, I'm not here to judge you. I'm just here to make sure, and I'm not going to tell them, that's not my business either. I'm here to make sure that you're safe. So not judging. Just because you're married doesn't mean, anything. I still want to know what kind of partners are you having, and how many people are you having sex with. So not being, not being judgmental.
And Dr. O, I love that. You even rephrase the questions for people who don't understand what you're saying, to like, because you could easily just accept the one answer that they give you and just, keep going within the conversation, but you don't. You say, okay, well, let me rephrase it to see if you'll answer it different this way. I love that you do that, because then that allows for, even if the person doesn't ask an open-ended question, you're opening up the conversations like to even have it. So with that, I want to go to Tito, because I'm gonna keep you involved as our college student here, right? I want to know, what do you think are 3 critical reproductive health issues that disproportionately affect Black women and girls, and what do you think can be done to address them?
I just feel like, as like my concentration is maternal child health, so I'll kind of touch on like the maternal mortality and stuff. I think that's one. Another one would also just be like access to like reproductive health services. And then lastly, STIs. I think that, especially as like a college student, with sexually like transmitted infections and stuff, a lot of the times people, the common trend is like being able to have these conversations, but a lot of people don't really like to talk about it. If you do get an STI, I think a lot of times people are very quick to like be really silent about it, try and hide it. Because one thing that a lot of peers will do is like, oh, like they're burning, or oh, like they're dirty, this and the third. And I just feel like it needs to be something that people like Stacey mentioned earlier, are able to have conversations about and be able to talk about, because it happens, it does happen. And like, it's not like a lot of times they can't be cured or treated. There are treatment plans that can be put in place to help the individual. And so I think that's one thing. And just making sure they're educated, because just because like, oh, you might get an STI does not mean that, oh, you're dirty or, oh, you're burning. Like that should not be something that should be placed on an individual, because I think it also does tarnish like their character as well. And it's really hard to come back from that, especially like I said, for like my age group, especially. So yeah, I'll stop there.
Dr. O or Stacey, would you like to comment? Okay. I'll just go straight to the next question. I am going to throw this question at Dr. O, actually, and then everyone else can comment, but Dr. O, because you are a provider.
Okay.
Why do you think, in your professional opinion, women of color do not use PrEP as much as their white counterparts?
Taylor, as much as I would love to say, give you a medical opinion, I have to give you a personal one. We are cocky Black women. We've been through it all, and we know he ain't that crazy. He's not gonna do it. He loves me. You know, something about Black women, when we hear, you know, he said he wants me to have his baby. It's like love. You know, you forget the six others they have that they're not taking care of, but he wants me to have this one. So it's going to be different. And, you know, whether it's coming from, I daddy issues, or all the other things that come with growing up underserved and underrepresented, that comes with it. These are the things that they're doing. Then you have the stigma, where I've been doing this for the last couple of weeks, asking my male patients, what would you feel if you went into your girlfriend's bathroom and you saw PrEP and you knew it was PrEP and it said on the bottle PrEP, so there was no confusion for some reason like it was HIV medicine? What would you feel? I'd be pissed off. Why is she on this? Does she think I have it? Is she messing with somebody who's had it? Blah, 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 blah. The same patient, the same girlfriend, you open her drawer and you find birth control. What are you thinking? Oh, I'm thinking we don't need to use the condom tonight. I'm thinking I'm glad she's on this, and it's like, really? That's what you're thinking. You're not thinking that she's on birth control and maybe she's having unprotected sex with other people because she doesn't want to get pregnant from them either. Like, that's not what's crossing your mind, but the PrEP, and that becomes shaming. Why do you think that you have to justify to someone why you find the need to protect yourself, which we really shouldn't have to. I shouldn't have to justify why I want to feel protected. But it's that stigma. Same thing if a woman has a condom in her room. What you got these for? Because I have sex, and that's why they're here. But it's also who else was here, and you having to deal with that, where I think our counterparts, because their male counterparts like aren't thinking the same way either. They're oh, good, you're on that, good, so am I, because we know that they are using it and they have the access to it.
And we actually have a question in the chat from one of our participants. And the question is, can breaking these barriers contribute in health equity? So anyone can answer that.
Oh yeah, once we can break these barriers, then we'll be equal. Then it'll be the same. Like, once one person can walk, both people can walk into the room and get offered the same thing, then we're there. But when we're still at the place that I walk in and my medical assistant has triaged you and I walk in and you're still asking me when the doctor is coming in, even though my ID says doctor and I'm wearing doctor clothes and I'm like, hey, I'm your doctor, and you're still asking me that, we're still a long way away.
And we have a follow-up from Sydney Brown. Sydney wants to know, how can providers create an empowering environment for patients so they develop trust and feel safe in being honest about what they're experiencing?
the providers, and these are my colleagues, you got to leave your judgments at the door. Your judgment is at the door. No one came for your opinion. They came for medicine. So your judgment at the door. If she's married and she has a boyfriend, that's none of your business. Treat it. You know, it's a 16-year-old that's having consensual sex with 4 partners. As much as we don't want to hear that, you connect her with resources, you know, maybe, you know, the therapist, we do this. And I continue with follow up, but I'm going to prep you up. I'm going to give you everything that you need, all the resources and everything that I can give to you. But the biggest thing is the providers, and they have to be willing to ask the questions. The patient's not going to answer it if you don't ask the question. So you have to also leave your discomfort at the door. When I ask patients, do you have anal sex? No. Why? I said, why not? And I say it in a non-judgmental way, and that I would say nearly 60% will go, well, maybe I do it a couple of times. And it's like, okay, are you having any problems, anything going on, blah, blah, and we can talk about it. But until I posed the question in a way that they knew that it was safe and I didn't have any judgment, that's when they were willing to talk. You know, and you just have to balance, you know, you have to balance that. And if you can't, then that's not the field for you, because we're doing more damage than we are doing good for each encounter that we miss.
I wish there were a reaction button so I can give some hand claps or something, because absolutely all the way around. And I would like to add to that as well, which is harder. I'm not saying these things are easy, because it is hard for folks to confront their biases, right? We already know that. So that aside, also when folks come through the door, when folks come into the lobby, how they are what's the word?
Greeted.
How they are greeted as they come through the door can make a whole bunch of difference. What they see in the waiting room, can they see themselves? Are they represented, right? Because representation is huge, y'all. We all know it. Representation is it's huge. We need to be able to see ourselves in some of these settings, and also in order to be comfortable and not have the attitude when you come to the front desk, right? At the front desk. How folks are greeted, how they're signed in, sets the tone for the provider. It sets the tone for Dr. O already, right? So I think, honestly, it's got to start there. It's got to start as simply as creating safe spaces in the office, in the waiting room, as they come through the door.
I will co-sign on that. I tell, you know, I work at a FQHC, and I tell the staff, you know, every day, I said, we cannot control what's going to walk through the door. We can't control the havoc that's going to come through, but we can control our attitude. And if we smile and we do it, it will make the day go faster, because we have 8 hours here. No matter what, we can't change the 8 hours, and we can't change what the person's coming from. And remember, everyone walking through that door is walking in because they need something. They're not coming here because they want to. This is not the mall. So just remember that. And I think we have a very good crew that does take that into consideration. And that does help the experience. And I will tell you also, like, even if you don't look like your patient, if you can practice cultural humility and cultural competency, because I work in a predominantly Hispanic community, and I always have, and I'm not Hispanic, but I've made it my business to learn Spanish as much as I can, and my patients appreciate that I'm trying, and we will Spanglish it out. And, you know, even if I have the interpreter, they don't want the interpreter in the room. They want that personal connection. And my Spanish has gotten very good, by the way. But, you know, I'm not, and my patients trust me. We have established a trust and a bond because they know that I care, because I have that humility. I'm not saying, well, why are you drinking this tea? You know, that's BS. We don't do that. I said, I understand that tea works, but I can't tell you how much of that tea to drink to keep you controlled. So I'm going to ask that you try what I'm going to do. If you want to take the tea and you feel this way, it might be because it's interacting with that. But I do acknowledge that that works. You know, and that goes a long way.
And I actually just received another question in the chat, and it's a great question. And I'm going to break it up because I want to hear what Dr. O and Tito has to say about this. So the first part of the question from Alyssa, by the way, I'm going to give you a shout out for asking a question. The first part is, Dr. O, to what degree do you think medical mistrust plays in the role for low prep use? And then Tito, I want you to follow behind her and answer from a Gen Z perspective, do you think that women are even concerned about using quote unquote this new medicine that may not be heard of to them? So Dr. O, you can go first, and then Tito, you can follow.
Okay, so sorry, I was focusing on Tito's question. Give me my first one. Give me my one.
No problem. So your question is to
Oh, the
what you
mistrust.
think. Yeah, do you
So the
think?
mistrust. So based on the person's exposure, the mistrust of the Black community, the African American community against medicine goes back to Tuskegee and all the experimentation. Even further than that, African American women have been used as human living cadavers, models to have experimentations done on them. This has been going on for years. So the mistrust is deep, because along with generational trauma that's passed down, these other stories of things get passed down, of things that were done. So it's very hard. One thing that does help, I think, is when someone does see someone looking like them, it's like, I'm not going to hurt you. The hurt that was done was not done by me. So please trust in what I'm telling you. So I have to build that, but it's valid. It's a valid trust, a mistrust, because it's there. It's happened. So people want to see, well, how long is this medicine been out? They don't want to be the experiments or the guinea pigs. So it's deep, but I do my best to let them know and try to rebuild the trust and let them know, like, I'm recommending this because I feel that you need it. I would take it if I had this condition, if my sister had this. And I usually start, and I'm a little different. I tell my patients, when you walk through this door, we're no longer patient and doctor. I just identified you as, based off your age, you're my cousin, you're my sister, you're my this. So if you don't like that, I'm not the provider for you, because I'm going to talk to you real. Excuse my language, girl, this is not right. And whatever the situation is, or young man, when you walk to this office, your pants need to be up. Okay, that's how I'm going to see you. And I said, as well as how people see you on the outside. So there's a little mentorship that comes with with my medicine. But yeah, I understand where the mistrust is and where it comes from, and I try to educate them as much as possible and tell them everything has a side effect. Every single thing has a side effect. Too much water, too much this, but if I have a girl who comes in and her hair's all dyed up, I'm like, I'm sure the bottler thinks that your hair might fall out, but you still colored it. We know what's going to happen to your nails after the acrylic comes off, because we've all been there, but you still do that. So why not protect this? The other day I asked a young girl, you letting him do this and this to you? You gave him the pin to your phone? Oh no. He can't have the pin to your phone, but he could have the code to your life. Like, that's big. You got to think about that.
And you said from a Gen Z perspective, sorry.
Yes, from a Gen Z perspective, are women concerned about using PrEP?
I feel like I'll speak from my own personal perspective. I've heard about PrEP, through like ads or like other things, like social media, stuff like that. But I don't know, like I don't have much information on it. And I haven't really heard any of my peers or any of my age mates ever like talk about PrEP. Like I feel like the only protective measures that are like ever taken for real are, with like condoms or like with birth control and stuff like that. So I would say from like a Gen Z perspective, I don't really think that it's anything that's as prevalent, which is why I do think, like I said earlier, education is very important, making sure that people know what options there are to help keep them safe and to safeguard their bodies.
And I think that's something that's off with the advertisements, because I've heard that a lot from Gen Z and other patients, that the commercials the people don't look like me. I'm not, woman, the other day I said, well, why aren't you on PrEP? And she goes, I'm not same gender loving. I'm like, what does that mean? She goes, I'm not a gay man. And I said, is that what you think? She's like, that's not what I see on the commercials. So the commercial pops up, that's the time to go start scrolling through my IG and respond to the message, because this commercial doesn't apply to me.
Mm-hmm.
So
yeah, and that's the thing I always see is like when I do see the commercials, it's typically like an ad of like two white gay men, and then that's all you really see. So I think more representation is really important as well.
they've gotten colorful. There's like a Black one with a Spanish guy, and but yeah.
And Dr. O, as while we're talking about PrEP, I actually have two questions. One is ours, and then one is from one of our participants. The first question is, how young is too young, and how old is too old for PrEP or any HIV preventions? So you can answer that, and then I'll ask you the next question.
All right. So my answer to that, if you're having sex, you're old enough. But the guidelines are 35 kilograms, so 70 pounds. If you're weighing 70 pounds or more, then you're eligible to be on it. How old is too old? If you can get it up and get it in, then you're able to. And we see that a lot in our nursing homes and our older senior communities, because we have a lot of men who may frequent younger women who have STIs, and then they're coming back to the senior setting. So as long as you have good kidney function, depending on which regimen we're choosing, or with our other ones, that's not even a factor. So there's no such thing as too old or too young, as long as you meet the weight requirement and all your organs are working the way they should.
Thank you. And this question actually can be for Dr. O and Stacy. Jatoya wants to know, how do we increase people's access to HIV data in their environment, because some people feel HIV has gone away?
They don't got Google? Where'd they hear that? You can go to CDC, website. You can look up, you can go, if you're in Maryland, you could look up the Maryland Department of Health. If you're in DC, the DC Department of Health, they have their numbers there. They have all of it there. And if you want the shortcut version, it's not going down. It's not going down in our area. In the DMV area, we are high. Nevada, I don't want to be lying, but Nevada, Georgia, DMV area, we're not going down. So it's here. It's in the neighborhood. It's around us. You may not see it. A lot of people may go out of their neighborhood to access care. And now with other options, people are getting virtual care. And with the advancement of the treatment, people no longer look the stigmatized way that you used to. So, yeah.
Yeah, I think again, coming back to having the conversations. So gone are the days, the late 90s and the early 2000s, the days when we had all the ads, we had all the interventions, we had all the prevention monies and messages. Those days are gone. So as a result, the message is gone, right? I think it is up to us, and it behooves us as public health workers, any of us who are working in public health at this moment, to continue to have these conversations. Because I still get the question, but Magic was cured, right? And I'm like, no, baby, no, he wasn't. Let's talk, right? So it's important to continue to have these conversations, I think, is what it is. And they have been lost. They have been lost with the efforts of public health, and they should not have been. So yeah, you can find it any of our, well, let me speak for MDH. It is on our website, and literally all you have to do is Google Maryland HIV stats. That's it. And you'll get a dashboard. There's a dashboard you can actually play with the type of information that you need. You can curate the type of stats that you want to see, that we have available. So yeah, the information is absolutely out there. It behooves us in public health and health to continue these conversations, to invite folks to find this information further.
Thank you. Does anyone else have any comments before we jump into our next question? Okay, so we can go to the next question. Dr. O, you look like you're about to say something. I thought she was
No,
going
no, I'm just excited. I love this.
I thought she was going to spit some more knowledge. Okay, well, this question is for everyone. What are some high risk and low risk safe sex practices? And if you have any HIV negative couples, would you recommend PrEP? And also, wouldn't that mean that someone is cheating or that they have other partners? Dr. O, you actually talked about this a little bit earlier, so
Yeah.
we're gonna bring it back up again.
Yeah, I'm itching. I hate the word high risk. I hate that term. I don't know what high risk means, because I will have a married woman who is faithful, and she's married and she's HIV positive. What is her high risk factor? Everything is telling us that she is not of high risk, except for the fact she's African American, right? If there's an African American female who's married and is positive. So, we're gone are the days of what we're thinking of high risk behavior. Having sex, even if it's one partner, in itself can be a risk factor. We don't know what that one partner is doing. We don't know how many other partners that one partner has. So it's yes. So there are no high risk. Somebody may think, well, I'm having sex with one person missionary and I'm not going to get it. Position doesn't matter. It's not something that it's just one person. It can happen. So there is no lower risk factor. The lower risk is abstinent. That's the only one I've seen no one get HIV with to date.
To kind of touch on the last question that you brought up about wouldn't that mean that somebody's cheating on their partner? I think that it should be normalized to be taking these precautions from very early on. Like Dr. O said, once you start having sex, you need to make sure that you are taking the precautions to make sure that you are safe and you're healthy. And so, you can always trust your partner. Just because you are taking these precautions, just because you're on PrEP, stuff like that, does not mean that you do not trust your partner. But also, you can never be too sure either. And I feel like if it was normalized, it's always normalized, yes, I'm on PrEP, or yes, I am taking these precautions to make sure that I'm safe. It wouldn't cause tension. It wouldn't cause problems. And it would just make it easier for everyone all around.
Yeah.
Stacey, would you like to comment?
I agree, Tina. Thank you for saying that. We have such, I love love. So let me just, I'm gonna temper that by saying I love love. But we have such a romanticized notion of being in relationship that we have perpetuated for girls, especially Black and brown girls. Everybody wants love. Yeah, we want love. However, it should not be put above your personal safety, right? We should normalize being able to prioritize yourself and your safety. I agree with Dr. O. That whole conversation about risk and risky conversation is, for lack of better words, it's dead to me because it doesn't mean anything. It means nothing of what we think it does. And if we are trying to change the statistics, if we're trying to change folks' access and approach to public health, if we're trying to change how people engage, we need to come to some kind of understanding that sex is actually sex, right? And who you thought was monogamous might be monogamish. Meanwhile, you in your head, I am the only. Baby, no, you're not. And then what happened before you got into this relationship?
Yeah.
Have you been tested? Have you been in care before this for your own personal acts and history? So I think we have to again get into the conversation of talking about it. I think I don't know, cheating notion just annoys my life on many levels.
We need, and I think I don't know where it started, but somewhere along the way, love looked like condomless sex. That was, I love you, I trust you. And we need to reframe love meaning, I want you to be protected. But before, and I think Stacey and I were talking about this the other day, before he can love you or you could love him, you need to love you. So that goes above all. And if he has a problem with that, on to the next, and that's it. So I try to empower my young girls and say, if he wants to have this, you have to tell him it comes with this, which is a condom. Okay. And I want to see your test results and you come with my test. And I guarantee you, I said, I will double book, triple book. I don't care if you ever come with your partner. That is one commitment. I will test that person with you at that time. So
make it a date.
Yeah.
This is our first date.
Make it a date, make it an annual thing. People go, well, I'm not active yet. I'm like, let's get into the habit of testing. So when you do become active, it's not this big thing and you can know it's not scary. But we need to start to change what love looks like. Love looks like protection. Love looks like keeping yourself safe. Love looks like we're not ready for a baby, you know, and that's where we need to start changing and having the conversation. So I really reach out to our pediatricians, and I know they didn't go into it, pediatrics, to have sex talks. They went in to play with the cute little babies, but we need to have these conversations.
And we have another question in the chat. Why do we have to go to an infectious disease clinic to get prevention medicine?
You do not have to go to infectious disease no longer. You know, that is part of primary care. And many places have that. So that's part of primary care.
And if your provider says that, get a new provider.
Mm-hmm. I'm in Greenbelt. For anyone in Maryland.
You taking new patients, Dr. O?
I am, always am.
All right. Y'all heard it.
Shameless plug. We love it. And the time is now 4:53, but I have one question for each of you. And the last question is, what specific strategies can be employed to destigmatize mental health issues and access within the Black community?
I think, in my opinion, openly talking about it. I make a point, I let anyone know I suffer from anxiety and depression. You know, and at one point I was told, you should keep that quiet. Nobody wants to have a doctor that I don't care, then don't come to me. But that's what I have. And I need you to know that I have bad days and I have good days. And I also want you to know that I understand what you're going through. I tend to give the patients the same grace that I would like to be given. So we have a 15-minute late policy. You're 20 minutes late. I get it. Things happen. Still come. You know, so the seasons change. This is rough for me right now. You know, I share with my patients. So, you know, the more we're able to talk about it openly, the more that we normalize it, then it's okay. Because our counterparts have been talking about it forever. They have, you know, oh, I'm depressed, I'm this, I'm that. So why can't we?
I think another thing that would be very helpful too is, you know, promoting more Black people to enter the field, like, and to be accessible for not only Black women and Black girls, obviously that's the focus, but just Black people in general, just to have something that they can confide in. Because I think the first challenge is to, you know, admit like, yes, I'm battling these mental health issues. The second one would be getting the help that you need to, you know, overcome it. And so I feel like seeing more people that look like you, that can help you, or more people that look like you that deal with the same thing. So, you know, like, okay, I'm not alone in this, because I feel like it's something that can make you feel very, very alone.
And I would just echo what Dr. O and Tito had said. Have the conversations. Secrets kill, right? Secrets kill and silence kills. Gone are the days where we don't get to talk about things. Let's talk about it. It's okay. I love seeing, and I'm seeing it more and more in books and in certain shows. Folks are going to, Black and brown folks going to therapy. Black and brown folks, please go to therapy. Please engage in mental health practices that'll make you feel better. Please be okay with accessing mental health care. It's okay. Everybody got stuff with them. Like, we should be championing, we should be normalizing. It's something that folks, it's a tool, right? It's a tool for healing. And at some point, all of us need a little bit of healing somewhere. So please don't be ashamed to access these tools that'll help you heal.
Mm-hmm.
And just based off of some of the comments that I see in the chat, it's okay to not be okay. I've been learning that, you know, like it's okay to not be okay. But one thing I have also learned from just my recent trials is that staying silent is not the answer, right? So in those normalizing those conversations, when you normalize the conversations, also celebrate your Black therapists and your healers, because they are the ones who are trying to make sure that you get what you need. They're bringing that access to you, and not just in proximity, but making sure that we even have these spaces in the first place, because we don't have a lot of them. But here we are right now on this Zoom call, and you have Stacy, you have Dr. O, and you have Tito, who don't have a problem with having these conversations. So before we close out, does anyone have any last remarks or tips? If you could give one piece of advice based off of everything that we discussed today, what would that one piece of advice be? And it doesn't matter.
Yeah. Mine would be life is way too short. Live it to the fullest as safely as you can with no regrets.
I think like one thing that we've commented on for each question was kind of just like have those conversations, be able to be comfortable and talk to others.
Agreed. Talk to your folks. It's not as scary as it initially seems. Talk to your folks. Talk to your babies. Talk to your aunties. Talk to your grand people. Because, yes, they are having sex too. Talk.
Mhm.
And I would like to personally thank, as we close out, I would like to personally thank all of you for accepting the invitation to speak on our panel concerning Black women and our health and what we need. So as we wrap up, because the time is now 4:58, I would like to thank everyone, our panelists and our participants for joining us today for the Breaking Barriers, Empowering Black Women and Girls in Health and Wellness. And we hope that this session provided valuable insights and empowered you to take actionable steps in your own health journey and advocate um, efforts. So if you found it today's session engaging, we encourage you to register to receive more information about our upcoming Empower Mentorship Program, where we will be exploring the nuanced pockets of sexual health and everything that we discussed today as it pertains to Black women, culture, and the circles that we experience. So please make sure that you understand that these workshops will unravel unanswered questions, inspire thought-provoking conversations, and leave participants feeling uplifted and empowered with their own sexuality. And you'll have a network because it'll be Black women, right? We love that. So the
Yeah.
links will be put in the chat so that you can have easy access to that. And as we wrap up, we also love to hear your thoughts on today's session. So please make sure that you provide us with your feedback because it is incredibly important and it will help us improve our future sessions. We will also be placing an evaluation link in the chat. So when you have a few moments, please take time to complete that and give us your honest review of how today's session went. And once again, thank you to our panelists for sharing your expertise. And thank you for all that you do to engage our participants in participating. Together, we are breaking barriers and creating a healthier future for Black women and girls. So thank you, everyone, for joining. And I
Thank
hope
you.
to see you all in person on Thursday at Howard University for our in-person day for the Stigma Conference.